Evening, everyone. This is a standing room only crowd. Welcome. Welcome to Politics Prose as we celebrate the publication of Dr. Ezekiel Emanuel's Reinventing American Healthcare. But we go beyond the colon to report, as the book title says, how the Affordable Care Act will improve our terribly complex, blatantly unjust, outrageously expensive, grossly inefficient, error-prone system. So this is not hosannas to the current system. I think the title tells us a lot. I'm David Cohen. I'm Carla Cohen's husband, and Brad Graham and Lissa Muscatine and the staff of Politics Prose really continue making sure that this store is a place where there is ongoing, steady civil discourse, not only in the discussion of books, but in the study of books, where you can have some wonderful adult education courses and on a whole host of subjects. But in celebrating tonight's book, we're celebrating a book that's really written by a person who has brought sobriety to the debate, gives us an incredible perspective, lots of good judgment, and he will tell us some of what he has thought about, written, learned, and contributed. For me, one of the things that is terribly important in this book is how to look ahead as to what the contributions can be of the Affordable Care Act and how it can change so that we move away from our terribly complex, blatantly unjust, etc. system. The other thing it does is Dr. Emanuel has really recognized the importance and the value of political leadership. And we all tend to be appropriately critical most of the time. But some of the time we ought to recognize when people really do the right thing and act in an effective, productive, useful way that begins to make a difference in people's lives. So I hope Dr. Emanuel will tell us what he's worried about, but also what he thinks is beginning to work well and will continue to work well. Let's welcome Dr. Ezekiel Emanuel to Politics Prose.
Well, it's a real pleasure to be here, and I have to say, walking here from the metro, you get nervous. You get nervous there won't be a crowd. Then you get nervous the crowd will be too big and you'll be intimidated. I'm usually not intimidated because I talk to a bunch of doctors, and I'm sure I know more about health policy than they do. But I'm also sure there's some people in the audience who know more than I do. So I want to begin and roll us back to a hot Friday afternoon in 2009 in the White House. A bunch of health policy people were meeting in the second floor office of Phil Shaliro, who was head of legislative affairs. We were arguing and debating. Present were Nancy Andaparle, who headed the healthcare reform effort, my boss, Peter Orzag, who was head of Office of Management and Budget, two people from the National Economic Council, Jason Furman, who was the deputy director, and Bob Kocher, who was the physician, and a few other people sitting around the table arguing. We had been there about an hour when the president walked in his shirt sleeves with his cuffs rolled up. And he was there to give us a sort of uplift. We had been working hard for 6 or 7 months at that point. He was just patting us on our back and giving us more courage to continue. After a few minutes, he said something which I think is remarkable. When he was talking about the Affordable Care Act, he says, you know, I feel lucky. I feel like we're going to get this. Let me remind you, July 2009. just before August 2009 that gave birth to the Tea Party in the attacks at many local town hall meetings. And then we quickly shifted from pleasantries to substance. And I raised with the president one of the issues that had been burning up the staff, the issue of something called the tax exclusion. Now, I'm willing to bet that most of you don't know about the tax exclusion. Some of you may be accountants and do know about the tax exclusion. It's one of those obscure parts of the tax code which turns out to be incredibly important. We got our basic employer-sponsored system through two major acts. The first act is from 1942. The Stabilization Act was passed because all the men going to war bid up wages tremendously, and prices were escalating because of all the materials needed for the war. And the Stabilization Act put wage and price controls in. And it had a very interesting provision. You couldn't raise wages, but it had this loophole, which said, well, we won't consider it an increase in wages that violates the law if an employer offers a prospective employee health insurance that's less than 5% of the wages. Well, this suddenly was used by a lot of employers to get scarce workers to come in and work for them. And then after the war, there were a couple of other decisions about the fact that unions that had bargained for this health insurance could continue to bargain for it, that employers had to honor it. But then in 1954, Congress passed a law, and the IRS issued regulations that basically said, you know, that health insurance that your employer's providing, that's basically tax-free. You don't pay income, and you don't pay payroll taxes on that. And the consequence of that has been profound. It's meant that, first of all, a dollar in health insurance is worth a lot more than a dollar in wages. And so workers will have a preference to get more health insurance. It also turns out to be incredibly regressive, you might understand. Rich people tend to get health insurance from their employer. Poor people don't. Rich people tend to get bigger health insurance packages than poorer people. And rich people tend to be in higher income tax brackets than poor people. And so this is one of the most regressive tax provisions that there is. Most importantly, it's actually far and away the biggest tax loophole there is in the United States. The mortgage deduction that all of us value, that's worth about $70 billion a year. Health insurance, the tax exclusion, $250 billion, $250 billion. And that's basically federal transfer right into the healthcare system. The big argument we were having was the people on what was called the economic part of the health team, those of us who work for OMB, the National Economic Council, the Treasury Department, we wanted to do something about the tax exclusion because it's inflationary, it's regressive, it's a lot of money. The political team hated this idea. David Axelrod, as part of this debate internally, created a montage of all the ads that President Obama had run against John McCain, attacking McCain's proposal, which was basically to get rid of the tax exclusion and give people a tax credit instead to buy health insurance, and reminded us that this was a firm view of the president. Now, the president, in all of our discussions about health care and many other things that I partook in, had a very firm principle, and he would re-emphasize. We got into some weeds, and he would say, what do we say about that? What was my position on that? Because the people should know that I stand by my position. And it was very difficult to get him to move off something that he had committed to in the campaign or in a speech. He had clearly committed to the tune of more than $100 million to not doing anything about the tax exclusion. Well, in this meeting, I suggested, when we moved from pleasantries to substance, I said, you know, Mr. President, as president, you can control a lot related to the public provision of health care insurance, Medicare, Medicaid, CHIP, veterans, health benefits. But you don't have a lot of power over the private side. And that, after all, is the bigger side. It's most of the money, covers half the American population. But, you know, changing the tax exclusion will have very important downward price pressure on health care and cost control pressure. He hadn't either understood that, been told that. It's not clear to me how it was, but this was new to him. And over the course of the next few days, this was Friday, then Monday and Tuesday, we had meetings around this. The idea began to hold that we should do something about it. We shouldn't roll it back, but we should modify it because this was a very important cost control measure. And that's how the so-called Cadillac tax started out and got into the health care reform bill. Now, David had mentioned political courage. One of the things I think that did require courage by the president was to do something on the tax exclusion. It is not at all popular with the unions, who have negotiated very big and luxurious tax health benefits that have the tax exclusion. And so he was basically doing something that wasn't good for a key element of his base. It was clearly something that he had to walk back compared to his statements in the campaign. But he also knew that this was the right policy, and he summoned the political courage to say this is the right policy. It may not be good politics, but it's the thing to do if we really want to have this essential element of health care reform, which is cost control. There are many other episodes like that I recount in the book. It's now exactly 4 years and 1 month after passage of the Affordable Care Act. I am notorious for saying I don't like people, you know, examining whether the water is boiling and taking too early an assessment of how we're doing. But I will do that for a couple of reasons. First of all, there are some, I think, important things that we can learn by what we've had so far, and it gives me a sort of opportunity to say what I think needs to happen since that time. The first thing I want to say is that we should remember that the Affordable Care Act is the product of a democracy. No piece of legislation in a democracy is going to be perfect. That's just not possible. We have diverse interests, diverse and competing values. We're going to not get an A bill. I'm a professor after all, so we always grade things. It's not an A bill. It's got problems. It's got, in addition, unintended consequences. But the important thing is that on the three major issues that motivate anything in healthcare: access, so that we don't have 50 million uninsured; quality of care; and cost, it's had, I think, thus far, a pretty remarkable effect. The access one is, you know, we've obviously been through bruising moments. But I was just today, Gallup announced that they've analyzed their data, and their data, which they've been recording for a while, said that 4% of the population has got coverage through the Affordable Care Act. New insurance, these are people who didn't have insurance before, have got new insurance. RAND estimated a week ago it was 9.3 million. So somewhere between 9 and 12 million people who didn't have insurance have gotten insurance in the very first year. And that's with an exchange, you know, that can only be described as, you know, kaput for 2 months and then back up operating at a B level. It's not, you know, REI, it's not Zappos, it's not LLB, now you know where I shop. Right? It's not there. That suggests that there is huge public appetite for health insurance that's affordable. And people will go through lots of issues to get that coverage. And by the way, Gallup says that a disproportionate number of those people who got insurance and had been uninsured are young. Now, very important, we still have some big hurdles. Lots of states still don't take haven't expanded Medicaid. I believe once we get past the 2014 election, we're going to have 7 more states come on, and by the end of the decade, we'll have all of them. The deal's just too good. Let's talk about quality of care, and this is probably the story that's gone the least noticed in the hullabaloo about the exchanges and other things. But the fact is, as the subtitle says, you know, the healthcare system in America has peaks of greatness, but it's really uneven. And there are valleys that are embarrassing, you know, hospital-acquired infections, medication errors, bad diagnoses, just lots of people, plain old simple thing, hypertension. You know, about 35% of the population has hypertension. A, doesn't know it, and B, is not well controlled, even if they do know it. That is an embarrassment. It's not a very complicated thing to do. The drugs aren't expensive. Part of the bill created this innovation center at Medicare, and one of the things that I'm proud to say I participated in is this thing called the Partnership for Patients, which was to work with 37 of the 4,900 hospitals in the country to try to improve their things like infections, medication errors, and other things that should not happen. Well, a report that's been released but has gotten almost zero attention shows that overall, on those 15 different scores, hospitals have improved 10%. On certain things, central line infections, infections because of a breathing tube, down 50% almost. Early elective C-sections, so a C-section that's done before 39 weeks when the mother's not in trouble and the baby's not in trouble. We used to have a lot of these in the system, down over 50% in these hospitals. Lots and lots of improvements. Again, direct result of the Affordable Care Act. Decline in readmissions, people who'd been in the hospital, got discharged from the hospital, and coming back within 30 days. We've had a steady decline since the bill, the provision in the bill that penalized hospitals for this has gone into effect. So it shows, first, hospitals can improve when they're forced to concentrate on it, and the bill put in place a system that could encourage that. Last thing, and the thing I've been most obsessed by, is cost control. We have a system that is a $3 trillion system. Now, Washington is the only place that might understand $3 trillion in the world. I like to say, you know, you got to put the size of the American healthcare system in context. $3 trillion makes the American healthcare system the 5th largest economy in the world. We spend more on healthcare in the United States than France spends on everything. France is the 5th largest economy in the world, right? All that great French food, those Burgundy and Merlots and great wines, right? Those vacations on the Riviera or in the Alps, those crappy Peugeots and Citroens. We spend more on healthcare than they do for all of that stuff. We're not going to change, therefore, the American healthcare system, you know, that fast. But we have also had an impact on costs. Over the last few years, 3 years, costs have come down to about the growth rate in the GDP, which is a remarkable change. Part of that's the Great Recession and people holding back. Part of that is the change in the way insurance is structured, so people have to pay a little more before they get the insurance. But part of that's also the Affordable Care Act. It has changed the way hospitals approach care. It has made a major shift in the whole design. I know that when I was talking to doctors 2 years ago, they were sort of in denial, not talking about it. Within the last 2 years, doctors or hospital executives are like, we know we need to change, and now help us change. Tell us how we have to change. That is going to make a huge difference. And now I'm going to conclude by talking about what difference it's going to make and what the future is. So the last chapter in the book is called Megatrends, and I make 6 predictions, knowing full well that making predictions is about the most dangerous thing you can do if you want your reputation to stay intact. One of my colleagues at the University of Pennsylvania, Phil Tetlock, once did a study assessing people making 28,000 predictions. And these were economists, and he compared them to intelligent, well-read. No, he did. He compared them to intelligent people who kept up with the news, and then to dart-throwing monkeys, i.e. random chance. Turns out that economists are no better than you are. And by the way, the more famous the economists, the less good they are. But that's probably no surprise to you. They're barely better than dart-throwing chimps. It really is. It's a very difficult thing to make predictions. So at the end of the book, having given that preface to it, I say, look, you got to make predictions. In part because if you're a hospital or a doctor, you're making predictions about the future. Are you going to build that building? Are you going to acquire these practices? Are you going to go into this market, right? If you're an employer, you're going to have to make assessments. How do I structure my insurance package? Do I continue to give insurance, et cetera? If you're an investor, a venture capitalist, or someone who's investing in the stock market, you have to make predictions. You know, what are the growth parts of the healthcare system? Am I going to make money? I'll tell you, a lot of students I know are making predictions. At Penn, we have, at Wharton, we have the only department of healthcare management at one of the major business schools. This year, 360% increase in the number of kids applying to that major, from 28 to 130 in 1 year. So they're making big predictions, right? They're making their entire careers predictions. So I make 6 predictions in the book, and I'll end with this. The first one is the end of insurance companies as we know them. They are no longer going to be taking premium, paying out, and saying no to you. They're going to become much more integrated with the delivery of care. Second, much more focus on people with chronic illness and people with mental illness to keep them healthy. 85% of healthcare spending goes to people who have chronic illness, and 10% of the population consumes about 2/3 of the dollars. If you want to control costs, you want to improve quality, you have to focus on that 10%. That 10% are people with chronic illnesses or multiple chronic illnesses. Emphysema, diabetes, cancer, hypertension, asthma, congestive heart failure. You got to keep those people healthy, out of the hospital, functioning. That's going to be the key to long-term cost control. Health systems are now working on that, looking at that, and that, I think, is going to be the wave of the future. And once they've figured out how to do it for the chronically ill, they're going to move on to the mentally ill, people who have depression, severe anxiety disorders, and others, because they also consume a lot. Third, the rise of digital medicine and therefore the closing of hospitals. The need for hospital beds are going to go down because we're going to be able to monitor people at home. We're going to be able to deliver much more care at home, and we won't admit people to the hospital that we can now take care of at home much better and more safely and allow them to recover faster. And that's going to change the dynamic around the country. The fourth prediction I make, which has gotten me into a lot of hot water, is the decline in employer-sponsored insurance. I believe if the exchange works really well, it does get to Zappos quality website and product design and a lot in the insurers coming in. I believe that people are going to get more choice in the exchange. It's going to be easier to administer, and especially young people are going to want to shop there rather than get it from their employer. And so by 2025, I think that's going to be a major shift. I also think we're actually going to see the end of healthcare inflation. We're going to see healthcare grow with the economy and not take more and more money away from other things by growing faster than the economy. That's because of many of the things I've mentioned before. The concentration on keeping the chronically ill healthy, the closing of hospital, being able to treat people more cheaply at home, etc. And the last is that medical education, which is probably the slowest evolving organism in the universe. We're still training doctors today largely the same way we trained them 100 years ago when the Flexner report came out. And that's got to change. There are so many inefficiencies in training that we could easily cut 30% of the time out. And basically, academic health centers, the large Georgetown, George Washington, Johns Hopkins, they're going to have to go through a very big transformation to improve their quality, to improve what they can do and how they train people. And I think that's going to be a major, major positive change on the system. So with that, I think I'm an optimist, as you can tell. We are getting better. The system will be better because of the Affordable Care Act. But notice I didn't say solve, cure, or any of those things. Healthcare reform is a constantly ongoing activity. There is no gold medal. We're stopped. We're done. We've achieved it. It is a constant need to reform. And that's good. It means full employment for people like me.
Thank you, Ezekiel Emanuel. I have to say, we're going to begin the question period. I know people are already lining up because you know the system. That's great. You have access to the system. There'll be a quality answer, and we'll do it efficiently. But I can't resist your mentioning the Flexner Report, which revolutionized medical education in 1910 and had a wonderful thing that stuck with me when I was a college freshman. That deals with the usefulness of useless knowledge. And so I think tonight we heard the Emanuel Report 2014. And that's a lot to look forward to.
That's a great honor.
We're going to rotate the questions. We're going to begin here, and then we'll turn to you, Carolyn.
I guess I should say...
Can you tell me who you are?
My name is Alan Kornblatt, and I am a doctor. And I've actually had the chance to practice medicine with friends in England, France, at one of the German universities, and in the military. So I really do know the systems that work. You've really not said if you still practice medicine and if you're on salary or if you bill for services. The problem with France is that the French are very practical about low cost of education. They're also very practical about end-of-life care, giving people dignity and respect, and that's it. In the United States, you can't do that. Malpractice is also much less of a cost. What you haven't said is that the present cost of the penalty is much lower than the cost of the median of what's accepted as the platinum plan and the bronze plan. And most people with any brains know they can't be denied if they get sick. So now I'll just finish off. One last thing. How has the University of Pennsylvania reined in costs?
Okay. Great questions. First of all, I don't practice medicine anymore. I was an oncologist, and at that time I was on salary. So I had, and I will tell you, at that time I had no idea what things cost, and it was a big mistake. Second, I do think you can look around the world and learn certain lessons, but as the sort of tax exclusion suggests, there are lots of things which are sui generis to the United States, and you can't import a system from overseas here. And there are many, I would not say that Europe has solved every problem. Every European country looks at its own healthcare system and is also scratching its head trying to figure out how to improve the efficiency, the consistency of quality, the access to care. They have many of the same defects that we do. And I actually think in the long term, the Affordable Care Act is actually going to be positive for the world. We're going to learn stuff about paying doctors. We're going to have some better quality metrics that everyone in the world can use that's a public information. We're going to learn about taking care of people at home effectively. Does that mean we'll have solved the problems? Again, we won't have solved them, but we will have made some improvement. And let me just say one last thing. End-of-life care is a big issue. I've spent most of my career, I started out my career on it, and I'm actually coming back to it now. As best as I can tell at the moment, and I'm doing an international study of 8 countries on it, I don't know that anyone has solved the end-of-life care problem. If you die in Belgium or in Germany, your chances, you're likely 50-50 to die in a hospital. You're likely to spend about a third of your last month in a hospital there. In the United States, it's very different. You know, a large portion of our patients no longer die in hospitals. Many of them get hospice. It's not perfect here, but we actually have made progress, and Europe is more where we were in the 80s than on this issue. Now, they spend less, and that's for lots of other reasons, but they haven't solved the end-of-life care nut either.
I'm Dr. Caroline Poplin. I'm a primary care physician, also an attorney.
Oh, boy. I'll watch my words.
Every OECD country has solved the access, cost, and quality metric better than we have. And as you mention, people say, oh, well, you know, Americans that will never accept socialized medicine. But Medicare is a very popular program. And the improvement that you mentioned in 30-day readmissions, that was a Medicare initiative, not an Affordable Care Act initiative. Is there nothing that we can learn from the Europeans?
No, I didn't say there was nothing. But I do think that importing, first of all, I think you've slightly overstated the comparisons. There's no doubt that many European countries, all European countries are better than us on cost. There's no doubt about that. They're down at about 12%, 10 to 12%
Right.
of spend. They have universal coverage, although even in places like the Netherlands and other places, it's not quite universal. It's like 98.5%. Nonetheless, that is true. They are very uneven on quality. I don't think that you can say that they're great on quality, and they recognize that they're uneven. They're better in some areas, worse in other areas than we are. But we can learn some things, but we can't learn about the superstructure from them, because we're not going to shift over to the way they have structured their tax system, their employment-based system, etc. It's just not going to work that way. So there are parts that we can learn from them, and I think there are things in the Affordable Care Act that we have learned from them. Let me just finish. The readmission policy, yes, the Affordable Care Act required Medicare to put in the penalties. It's not like Medicare did it out of their own free volition. Tell me who you are.
Pete MacDonald. I'm not in the medical world. I've tried to follow the development of this legislation. Paul Krugman had a column last week. Someone here might remember the figure he gave for the number of premature deaths amongst Americans because they lack access to medical care. Does anybody remember the figure? It was in the thousands. My question is that, I know that's a tricky thing to come to. How do you prove it? But you do see this figure given. My question is there a respectable figure on that point? How does one establish it to the critics of American healthcare who will quickly say, too fuzzy, you can't do it? And if it's true, how can the Republicans and the opponents of this look their fellow citizens in the eye to oppose
All right. Okay, I
medical
got the
care?
question. In the 4th chapter of my book, I talk about the problems and the consequences of the system we have, including the consequence of being uninsured. And I have this graph. Page 98. It's a graph about cancer care and insurance status. And one of the things it shows is that your chance of survival, 5-year survival, depends heavily on your insurance status. About 10 percentage point difference, all taken across all cancers. Now, I would just say that if I had a drug that cured someone, gave them an absolute boost of 10%, I'd be getting every single award you can imagine possible. We consider a lot of home runs in cancer care, 3 and 4% increments. Now, people will come back and say, well, that's because people who are uninsured, they don't go to the doctor early, they end up with a bigger cancer. They also, tend to be poorer, they smoke more, they drink more, they have different kinds of cancers, lung cancers, esophageal cancers, which do worse. But even when you control for what we call the same size, the same stage, the same type of cancer, people who are uninsured do worse. And we don't know exactly why. Other people have done similar studies. There's an economist who looked at accident victims in Wisconsin, I also cite in the book. And he said, well, someone who gets in a car accident you would think would not make a difference what insurance they have. They just go to the emergency room and they get patched up. Turns out to be false. Makes a difference how fast they're treated, makes a difference how long they stay in the hospital, how much recovery they get, and ultimately their mortality. So the claim that people have made, and Mitt Romney made this during the 2012 campaign, that no one died because they didn't have health insurance, is just patently false. And it is an embarrassment to our country. I don't know what the exact number is, but it ought to be 0, right? We should not have anyone who dies. Now, it is true you can get to the emergency room, but as that study on emergency care after a car accident says, is that's not good enough. Something happens, and no one's quite sure what. How you're treated in that system if you don't have insurance. That's unacceptable, it seems to me, in the United States. And that's why one of the reasons that I think, I'm personally obsessed about getting everyone health insurance.
Yeah, hi, I'm Gene Rothman. I'm retired now, but I was on the business end of healthcare. I managed a mutual fund that invests in healthcare companies.
And do you have predictions for the future?
I'm asking you for a prediction
Oh,
for the future.
okay.
Where do you think fee-for-service is going? Do you think it's going to more or less stay the same or change a little bit? Or do you think it's going to dramatically change, such as capitation per year, or in the case of oncology, capitation per course of therapy? Or is it going to go to a salary model because we have more and more large groups and even small groups being acquired by hospitals, and the most recent trend is being acquired actually by insurers, which you touched on
in the book.
obliquely a little bit. And if it changes in any of those ways, do you see a major impact on healthcare costs, or is that just that's not a big deal?
Yeah. First, so the fee-for-service system is you go to your doctor, you pay probably a copay, your insurance pays him or her for the treatment, the tests, whatever else is happening. That system has to change. If we're going to get cost control, we're going to get quality of care, we have to move off that system. Again, that's not going to happen overnight. That's going to take time. But that payment system now, other countries have that kind of payment system. France, they have that kind of payment system. They can control costs through other mechanisms that we refuse to have in our country. So we're going to have to move off that fee-for-service system, and I see us moving off. If I have one major disappointment in what I could have done in the Affordable Care Act, we didn't do enough on that particular issue. I tried, and I recount some of the stories and frustrations I have with it in the book, but that, I think, is the thing that really needs to occupy us for the next 5 years, how to smoothly shift us off fee-for-service. And I do think that's fundamentally important. Just going to salary is not, I think, going to be the, lots of people think that's great. It may be great, but remember, there are lots of things you need to incentivize doctors to do. You want them to do good quality medicine. You want them to be cost prudent. Salary has its other problems. Places that have gone to salary have seen, doctors not necessarily adhering to things that they ought to be adhering to, lack of productivity, they slow down, they're not so invested in it. So I think we can't give up all incentives, but we got to structure them in a different way. And they don't all have to be financial. So I see a big change, and I think this is one area we're going to see a lot of change over the next 5 to 10 years. I'm engaged in 2 projects related to that right now. Actually, tomorrow we're meeting, a group of us are meeting and talking about how to change physician incentives given all we know about behavioral economics. And again, not just financial incentives, all kinds of incentives. Because I think we need to take the best of psychology, behavioral economics, what we know about human behavior, and put it into incentivizing doctors.
But what do you see as the change itself? I mean, you didn't talk about capitation. What other? What are you talking about in terms of?
I talk about it.
By the way, as you guys were debating all of this, I was scratching my head and saying, "Where the hell are they on fee-for-service?" I didn't see much, and now you're answering.
I think the easiest change is what's called bundled payment. Taking an episode like cancer and saying, all right, if you got diagnosed with colon cancer, we're going to give you 6 months or a year, the 6 months of treatment, and then the 6 months immediately after, and then we'll pay you if it comes back, etc. And that, you get a bonus if you adhere to guidelines and quality that we've agreed to. That's the second project I'm involved in, is to try to define those bundles. It's hard work, lots of hard work, and you need good quality metrics so people are, I'm not getting less care, I'm not getting the cheapo stuff, I'm not getting the stuff that won't cure me. So it does take a lot of work, but I think that work is going on around the country, and we're going to see a lot more of it. So I would, if I were a betting man, by 2025, at least half of payments will be off fee-for-service, and maybe as much as 75%. Oh boy.
My name is Harvey Fernbeck. I'm a physician, but not a lawyer. And I'm a member of Physicians for National Program. We believe in single payer simplicity, Medicare for all. As you know, the president is for single payer. He said it. He's for Medicare for all. Nancy Pelosi's come out for it. Harry Reid has. Recently, John Podesta, when he signed up for Medicare, said, hey, I signed up for Medicare in 5 minutes. How about single payer? And in a recent discussion at Center for American Progress, Senator Daschle said very vigorously he was for a single payer, but not for if it was not for the politics. Do you have any philosophical problems with single payer aside from the politics that would achieve all?
Well, first of all, I think someone once said it's not going to happen, so I'm not wasting any time on it. I think that was Jonathan Gruber, economist at MIT. It isn't going to happen. So let's just get clear. It ain't going to happen. We barely got the Affordable Care Act through. Single payer, zero chance. Okay? So let's just be clear on that.
No, I'm not. I don't think that's clear. I mean, because you could go 25 years in advance, and I'm not saying we do it in 6 months or by the end of this talk, but to say that 60% of the American people, who are for it, can't have what they want, and it's not going to happen. I think that should be.
Let me repeat myself.
Please.
All right. Certainly in my lifetime, not happening. Okay? So I'm not wasting any of my time on it. Okay? Let me just say philosophically, I also do have some disagreements with it. Okay? And it depends what you mean by single payer. You don't want to have one system determining payments like Medicare does for 310 million people. I don't think that's an efficient system. There are many things Medicare does that aren't efficient, that they can't do, and they have to do slowly because they're affecting so much of medical practice and so many people. Second, you do get a lot of political gridlock. A lot of what Medicare does is a response to political pressures rather than to top quality policy pressures or policy ideas. Second, you do want to have a lot of experimentation. We don't know the best way to care for someone who's got chronic conditions or mental illness. We just don't. We need to experiment a lot. And I think if you have single payer, it gets hard to experiment on those things. So for those reasons, I'm not a wildly big advocate of it because I think it would slow down the ability to make changes. Having said that, you know, I also don't think it's politically going to happen. And so, you know, we couldn't even get the public option, okay? I mean, and we barely got this bill through. It has failed 100 years worth, okay? All right.
No,
No.
Okay, thank you.
Lots of people have questions. I'm happy to argue with you till, you know. Uh-oh. I am a black belt in Taekwondo. All right.
Yeah, hi, Tony Hausner. We've corresponded.
Yeah.
I'm a health policy analyst formerly with the Medicare program. First of all, I think it's important for us to still emphasize that many people can still enroll in Medicaid throughout the year, and I don't hear enough being said about that. Given the successes that we've had, despite some of the problems, I mean, 7.5 million people signed up for private insurance, several million signed up for Medicaid so far. That message is getting out, and yet you still hear Republicans with all their criticisms still gaining headway. So what are some of the best things that we can say to get the word out that this is a success? It's important that we continue this program.
Well, first of all, it is going to continue, right? We're guaranteed through January 2017. Right. And I do think the Republicans knew it, right? They knew that unless they stop the exchanges, it's going to be an institution in the country. That's why the rhetoric got so heated. I actually believe, I think the bad rollout probably meant we'll have 2 more elections fought somehow on health care. It may be that the success has meant it'll be 2014 and everyone will look, you know, how did people who supported versus people who didn't, how did they end up doing? I think we won't know until after that. But I think it's going to go away because I think that overall people are going to, you know, find it okay. And let me tell you something. Every insurance company in the country, right, they're planning their future on Affordable Care Act being the law. Every drug company, same thing. Every device company, same thing. Now, they all want little changes, but the big picture staying the same. So I don't see repeal in the future. It does get back to what you said, which is the communication strategy around both getting it enacted, what it means for people, and its successes. Episodically good, you know, the achievement here, the President's September 2009 speech where he pulled the rabbit out of the hat after all those bad town meetings. But as a consistent matter, it has not been where it needs to be for this kind of program. By the way, there's a lot of hostility to the rollout of Medicaid, too, and Medicare, I mean, too. You know, doctors didn't like it. Hospitals didn't like it. Nonetheless, within a short time, it became institutionalized and part of the fabric, and there was no chance, no way you were going to take it away. And I think that's going to be the same thing here.
My name is Kate, and I'm one of those unimportant people who lost my health care. I was paying $700 a month for fabulous health care for a family of 3. We're all very healthy. My husband and I work out every day. We don't eat at McDonald's. We know how to eat healthy, so therefore we're responsible adults. And I don't like having to pay for those people who eat at McDonald's, eat a lot of fried food, don't work out, because my car insurance, I get credits because I've never had DUIs or car wrecks. And I've raised responsible children who never had DUIs or drug issues or whatnot. So I don't want to pay $700. I was paying $700, which was enough, but I just got a letter saying, oh, if you want to keep your doctors and you want to keep your plan, it's now $1,500 a month. And on top of that, your deductible was $2,000, but now it's $6,500. And it was not a health care plan that was substandard unless you think Harvard-educated doctors are substandard. My doctors were from Harvard. I selected them because I'm intelligent and I know how to read and select my own doctors, and I don't need the government to hold my hand. So I applaud the desire to cover everyone, and I think that everyone should have access to health care, but I do think that in the long term it may be helpful, but in the short term you need to go back and your peers and look at why you think I should pay $800 more a month. I don't need mental health care. I may after this because the stress has put me through, but if I need it, I'm smart enough to elect it, and I certainly don't need maternity care because my children are in college. And last but not least, I'm caring for my father, World War II vet, and I can tell you that the government can't handle the VA part of health care, so I don't know why you think you're going to be able to manage affordable health care. I'm begging right now to get my 87-year-old father someone, and I agree, we should let them live in their homes. That's my father's wish, and I'm going to do it if I have to take on 3 jobs. But now the $800 that I could give him every month to help him stay at home, I need to give to my own health care. And I can't get, no, hang on, $60 a week, sir, $60 a week from the VA for my father to take a bath, okay? So.
I'm sorry, I don't know the particulars of your.
Well, there's lots of people like me, not just me, sir.
I don't know the particulars. Well, it turns out that there aren't as many people as was claimed, like you, that number is probably less than 1 million and probably less than 500,000. That's the first point. The second point is you are not going to pass legislation for 300 million people and not have a situation where some people are going to be worse off. It's just not possible. Okay? It's not possible. The idea that everyone's going to be better, Pareto, optimality is going to be better for everyone, just not possible. The last thing I would say is you did benefit from the bad, awful, terrible insurance system we had. You were healthy. God forbid you should have been sick, because then one of 2 things would have happened.
No, I didn't have exclusions. I know my caps.
No. One of 2 things would have, but they wouldn't have renewed you the next year. You would have been SOL, as they say, okay? Because they wouldn't have renewed you. Or if they had renewed you, they would have jacked up the rates tremendously.
But I would have saved that from the $700 versus the $1,500, and I know how to invest, and I would have been able to pay for myself.
Now, God forbid you should get cancer. God forbid one of your kids gets hit by a car, not because they're bad, but because bad things happen. God forbid they get an appendicitis or need something else.
Well, no, now I have no insurance, so yeah.
It would be covered on an insurance plan. So that there is a reason. We have this. You cannot, in the old system, you're right, people who were healthy and had luck, because being healthy is lucky.
Well, no, you can also work at it.
They did well. But the moment they became sick, they didn't do so well. and lots of people who weren't in the system didn't do well.
If you lay in
and
bed
so
and
you
drink
were
every day
very
and eat
lucky,
McDonald's, you're not
and
gonna be
I
healthy.
don't think we should have a system that should be lucky.
Okay. No, my insurance covered it, but I'm not. I said on bottom line is.
Hello, good evening. I'm actually a registered nurse, and I'm in the trenches. I'm not
Okay.
a doctor, but we do play a large role in hospitals and healthcare, and it seems like that we're always kind of overlooked in this aspect. I was a nurse since '85, and I had the pleasure to work 13 years in Rome, Italy. I speak fluent in, Italian. I worked both the private and the socialized medicine. I worked both aspects, so I saw both for 13 years. And I find the difference I saw when I came back in 2003 here in the United States was great. Number one, we talk about Europe, but in the United States, unfortunately, I'm going to say things you may not agree with. Healthcare is a business, and not once has anyone mentioned that. In Europe, it's not. For instance, I'll give you a very basic example. You are not allowed to go on TV and advertise medication at all in Italy. Now, I'm only talking for Italy because that's where I live. For instance, you'll go on.
Do you have a question?
Yeah, I have a question.
Okay, what's the question?
It seems like it's not addressing the problem. The problem are several for socialized medicine, and you talk about doctors.
Well, what problem you want me to address?
Doctors, for instance,
Okay.
here in the United States, one hand doesn't look at the other. There is no communication system. I guess the problems are much
Good.
more than just money and offering insurance to everyone.
All right. I absolutely agree with that. And I think the coordination of care and the fact that we have a fragmented system is a serious problem. And it's especially serious for people who have chronic illness and therefore have to have multiple doctors. And the fee-for-service system, the payment of doctors to do particular things, encourages a fragmented system. There's no incentive for me to spend the extra time to coordinate with other doctors, nurses, home health agencies, rehab facilities, etc. Now, I think, again, if you take the premise that an incentive to control costs and an incentive to improve quality built in are going to actually incentivize better coordination of care, because there's lots of evidence that what's called the handoffs, the passage between one doc and another, a hospital and a doctor, a lot of problems happen there, and they add considerably to costs. Not focusing on coordinating care is a very high, costly problem. One of the major ways that the system is going to change is to have much more coordination, much more linkages between the different providers. In addition, we're going to integrate aspects that hitherto no one's been incentivized to integrate. Monitors at home, people to go to the house to make sure patients are taking their medications, etc. So I couldn't agree with you more. Actually, the book has lots of different illustrations of how the fragmented system actually undermines both quality and increases costs, and why I think the incentive structures are going to change.
Hi. My name is Tony Drexler.
Yeah.
I'm an international health consultant.
Okay.
Have been for about the past 20 years, 25 years. And my question really is asking your perspective on why we did such a terrible job of framing the issue of health care, and why we have been mousetrapped again and again and again and again in dealing with the promotion of it and the politics of it. And who's to blame?
Well, there's
Your
plenty
brother?
of blame to go around, and maybe the blame goes way back to 1948, and when Harry Truman tried to get healthcare reform passed, national health insurance after his victory in the 1948 election. It was at that time that the American Medical Association hired the first real political PR firm, Whitaker and Baxter, out of California, to run a campaign against Truman's proposal. They actually assessed every doctor $25 after Truman got elected to oppose his plan. And they, at that point, ended up coining the notion of socialized medicine, and you don't want to have the government involved or get between you and your doctor. Now, that canard has stayed with us from 1948 to today. And you saw it in the campaign over the Affordable Care Act, right? You don't want government involved in health care. You saw that Frank Lutz tested the government takeover of health care over and over again, and that was their version of socialized medicine. And, you know, it's pretty effective in America where we're suspicious of government. Government has screwed up in a number of ways. Look at the rollout of the exchanges. And it reinforces in people's mind they can't, you know, they're Keystone Cops, they can't do anything. That is a problem we have to counter all the time. All right? Now, I agree. And we did, well, actually we did a lot of things from the beginning to counter it. One is to take the usual suspects, the AMA, the Hospital Association, the drug companies, the insurers, and get them to collaborate and support reform. Again, there's a remarkable change in this time. We learned from the Clinton effort that we have to deal with those and make them supportive of health care. And almost all of them, especially the doctors and drug companies, were very supportive. The insurers were, you know, plus minus all the time. They couldn't decide what they wanted. Now, you know, they should be writing thank you notes to Obama. All of their stocks are at the highest level. They've actually done very well. And they will continue to do very well. But, you know, I think the communication strategy was not optimal. I point out in the book that's one of the major failings. I think, you know, what we should have done was get a bunch of doctors in white coats, put stethoscopes on them. Get a bunch of nurses, white coats, put stethoscopes on them, and give them a slide deck that explains it in ways people can understand, explains the problems, and explains how we're going to address the problems. That didn't happen. A couple more questions?
Yeah, we're going to take everyone who's in line. So if you're in line now, you're going to be considered. We're not going to stop anyone who's in line. So this is it.
That's a lot of pressure.
Okay.
Hi, my name is Natasha Clavel. Thank you for taking questions tonight. I'm wondering if you have any thoughts on the possible effects that the ACA will have on public health agencies and specifically on their ability to be able to still provide services for those that will remain uninsured.
That's a really good question. So even with the Affordable Care Act, the uninsured rate's not going to go to zero. For one thing, and the undocumented are excluded from the system of insurance. And so there will have to be provisions. It's recognized in things like the fact that DISH payments, the disproportionate share that go to hospitals to take care of the uninsured, have to continue. And even with the mandate, not all Americans are going to get insurance for one reason or another, ideology, not understanding, etc. So hospitals and systems are going to have to be in place. Now, whether we need a whole public health infrastructure like we have, to free clinics and other things to take care of them, I think that's yet to be determined as to how the system accommodates them. That's one thing which I have to say I do not have clarity on to be able to make a prediction for the future. I will note there was, I think, a story in NPR about a free clinic in rural Arkansas that just closed for lack of people coming to them because they'd gotten insurance or they gotten Medicaid. That's a positive. That's something we should celebrate, it seems to me, because these people now have a source of continuous provision of care that they can choose.
As long as you have an insurance system, insurance industry and a drug industry and an FDA that basically rubber stamps and fast tracks drugs and acts oftentimes more like a cheerleader than to the benefit of consumers, how are you going to change the paradigm of pill for every ill? There's no provisions in this for alternative remedies that work just fine, that have been proven by thousands of years. And yet we're locked into this paradigm which causes all these soaring costs, and it's just, it seems like a non-starter in a lot of ways.
Well, first of all, I'm not sure I would agree with your characterization of the FDA, et cetera. But
what about Vioxx?
I think
killed 60,000 people.
Violence?
A lot of Vioxx.
I think
Extra, Avandia, Januvia.
Look, there are hundreds of drugs out, thousands of drugs out there. We're not going to get, they're stuck between effectiveness and risk and trying to make that balance. Are they going to get it right every time? No. And sometimes they're not going to have all the data.
What about the
Wait.
influence that
Let me
pushes
finish.
us through?
Let me finish. They're not going to have all the data. I don't envy them. That's a very hard job to do, to make the choice right. And every time. I would say that I do think we're going to see a different mode going forward. As I have said, and let me emphasize, part of the sweet spot of the system going forward is going to be preventing people who have chronic illness from getting sick and preventing people who are healthy from getting chronic illness. That is going to, I think, focus on two things. One is not every pill for everything, because that's an expensive way of doing it, but making sure that when people have prescriptions, they actually take them, and you monitor their side effects and you monitor their impact for health. And I think that is going to be very, very important. You know, right now, today, you give someone a prescription, the chance they're going to fill a prescription? No, it's about 70%. The chance that they're going to take it once they have the prescription correctly, another 70%. So you are down to half of people taking their medication correctly. All right? Now, that is unacceptable. And one of the reasons people don't, do well is because they're not able to take the medication. Well, we're going to have a whole slew of new inventions. We already have them, glow caps and other caps, that actually encourage people to adhere and inform the doctor if they're not actually taking their medications. These kinds of things are going to proliferate, and I think going to be very helpful in improving the health and keeping people more healthy. And it's not just lots of pills. It's a way of making sure people are actually following their orders.
What about a much greater emphasis on preventive?
Lots of other, again, one of the things I talk about in the book is the fact that lots of people say, look, there's no prevention in the bill. It may not be what you want, but there is a fair amount of prevention. And by the way, the bill isn't the only health measure we worked on. I worked on the First Lady's Let's Move initiative to change eating and exercise in this country, and we're beginning to see effects. It's a little early, but we're beginning to see effects. And I think you have to look at these as working together.
Yeah, my name's Bob Like, and for most of my career I worked for Congress, and from roughly the fall of 2006 until August of 2009 I worked almost exclusively on healthcare reform, working with the committees and a number of member offices. A number of economists would certainly agree with you when you argue that by reducing the fragmentation and increasing integration, focusing on quality, we're likely to not only get better health care, but also bring down costs. But they also see that by doing this and encouraging it, the Affordable Care Act is increasing economic concentration within health care. And in almost every other industry, when you increase economic concentration, over the long run, costs go up. Costs go up more than they would under the previous system. Do you have any views on that perspective?
I have really strong views on that perspective. So one of the problems of coordination is and creation of these things called accountable care organizations is the worry that you'll have one big hospital which will buy up a lot of the little hospitals, buy up the doctors, and basically have a monopoly. One of the last things I was doing in the last 6 months I was in the White House was chairing actually a group. We brought together the DOJ, Department of Justice Antitrust people, the FTC people, and Medicare, which they rarely talk to each other, to try to get everyone to agree on what would the standards be for antitrust, what would we be looking at in terms of if people did combine in healthcare and quality in the area. Unfortunately, that didn't, after I left, it did not continue. I do have the concern that you have, which is that we could have excessive concentration. I would guess that my main mitigating worry about that is these big plans are going to have to begin bidding in the exchanges. You're already seeing this with Long Island Jewish in New York has put itself onto the exchange directly. No insurance intermediary, they're going to take insurance. Mount Sinai has, I don't know whether publicly or just to me, has said that by January 2015, they're going to have a Medicare Advantage insurance product. Mass General and the Brigham in Boston, they bought Neighborhood Health. So they're going to begin offering insurance, and they're going to have a good incentive to, I think, lower costs once you're on the exchange. Because people, we know, price is a very important determinant of what they're going to shop for. And so they're going to expect high quality and low prices. So that's my mitigating hope. But I agree with you. It's one of the things I was most concerned about 4 years ago, and I'm still concerned about it.
Thank you for your excellent book and your talk, too.
Thank you.
I'm a doctor here in D.C., and I teach health policy at George Washington. You know, I'm guilty, as so many of us are, practicing sick care and not health care. And doctors now are concerned also about the lack of time that we have with patients and how we're reimbursed to do more to patients rather than more for them.
Mm-hmm.
So how do we increase reimbursement for time with patients and not just for procedures that are done to people?
Well, moving off the fee-for-service is going to be the key to doing that, because I don't think we're really going to revise the fee-for-service system to actually change that payment structure. But once you move off the fee-for-service, if you look at high-quality primary care practices that do achieve high quality and low cost, almost all of them, again, what they do is concentrate on people who have chronic illness, not the worried well. They expand the amount of time that you're dealing with those patients. They bring in other health professionals. The doctor's not the only person there. He or she is part of a team that involves nurse practitioners, health aides, and others to provide care. You don't have to, you know, I remember when I was practicing oncology, there's plenty of stuff I did that didn't require an MD and was a waste for me to be doing. And I think changing that dynamic so that the physician has more time with the patients who need it and other health professionals focus on patients. Again, that's one of the things that's going to evolve over the next decade to, I think, be much more standard in health delivery, because it makes economic sense and it makes quality sense.
Hi, I snuck in here, but I'm a physician at a newly formed ACO, patient-centered medical home, and we have 4 MDs on staff, 1 nurse practitioner, a chiropractor, I'm the chiro actually, acupuncture, yoga therapy, naturopathic medicine, and behavioral health psychology. For an organization like we're trying to show how future patient-centered medical homes can use this model and it can be sustainable and get better outcomes. How would any suggestions until we move from this fee-from-service sort of thing of how we can make this work, because we just opened in May?
Well, I think this is where, you know, different contracts and at-risk contracts with your insurers is going to be the important thing. You're going to have to prove to your insurer that you can actually reduce total cost of care, that these other services actually have a benefit in reducing total cost of care. And, you know, if I were advising a group like that, I'd say, all right, who are likely to be your high-cost users, and focus the kinds of resources they need so that you can keep them healthy and out of the hospital. Because the total cost of care is, you know, not exclusively driven by hospitals, but they are the big kahuna. They're, you know, a third of all healthcare dollars. And I think focusing on changing that dynamic is going to be critical.
Hi, my name is Lee Hilling. I'm a healthcare administrator. For the past 35 years, I've run university and teaching hospitals in the United States and Africa and Asia. I want to thank you for an articulate and energizing presentation, and a positive one. I hope that we can keep optimism about where this is going with all its faults, and you're an important part of that. In your book, I just bought it, and I looked in the index, and I see you have several lines on accountable care organizations.
Right.
Many of the things that have been talked about tonight that you have said and others have said should be incentives in our system, I think can be embodied in ACT, and that's one of the things that's kind of under the radar in the debate. My last count, I think there's about 325 accountable care.
I think it's over 400 now.
Over 400. So
yeah, 200 really in the 200 plus in the public sector, 200 plus in the private sector.
Across the country. So,
right.
And I've been invited and have been for the past several months on the board of the Johns Hopkins University's Accountable Care Organization, representing about 3,000 physicians and about 40,000 Medicare beneficiaries in the Baltimore, Central Maryland, and Greater Washington, D.C. area. And everything that could happen that's good that I saw in my many years of running university hospitals that's wrong with the incentives is changing in this model.
Great.
The non-doctors, the healthcare providers, the focusing on those that are the high consumers, population health. If you would speak just a little bit to that, I think accountable care organizations are going to be one of the biggest change agents in American healthcare And I'd just like your thoughts on that.
Yeah, so accountable care organizations are, as you say, composed usually of a hospital with doctors, and they try to integrate the care, and they are incentivized, at least in the federal government's plans, mostly to share any savings they have in managing patients. Truth be told, I actually think the accountable care organizations is an intermediate species in the evolution of healthcare. They're kind of like Neanderthals. They're going to die out as we move to integrated delivery systems. So Hopkins, actually, it's already pretty much it's got an integrated delivery system because they take Medicaid and they run a full-service Medicaid managed care plan. And I think increasingly you're going to see them list themselves on if the Maryland Exchange ever gets running, on the Maryland Exchange. You're going to see them contract directly with employers to provide coverage. And so I think that integrated delivery system, or what I don't call in the book, but what I've been calling now that I've been talking about it, the Kaiserification of American healthcare, I think that's going to be where we're going. And so I do see this as a sort of intermediate step where people figure out how to coordinate care, figure out how to work together between the hospital and the doctor, so not every patient who used to go into the hospital does. And I think that is going to be the wave of the future, especially as they begin to take directly the payment. Then they cut out the insurance company's profit, passing the paper back and forth. And I think they said, you know, look, if you're a chief executive saying, why am I paying them 7% for the paperwork, their profit, whatever it is, I can keep that. Or I can reduce my costs, compete with them, and my brand, Hopkins brand versus, you know, an insurer is much better. And I think that's going to be the dynamic, again, going over the end part of this decade. Thank you.
Thank you. Thank you, Ezekiel Emanuel.